Okay, guys. Hi, welcome. We're going to just run through a few practice vivas, and this is, I guess, what I'm trying to do here is give you a bit of a taste of what it's going to be like in the real exam. You'll be coming into the viva. It's about a sort of a 25-minute, half an hour session. We've got a bank of questions that you're not expected to get through everything, but we just have extras there in case you are fast. And maybe just one of the things to say is that I think the exam is extremely clinically relevant in terms of answering questions, which is sort of what this whole practice thing's about. I guess I was trying to suggest that maybe keep it punchy. Go for the money straight away, and keep it flowing. You'll have maybe 3 people sitting in the room with you. It's either 2 or 3 people of the examiners will be there, and they're all clinicians. One might not be a critical care physician, but they'll certainly be a specialist in something. Okay, so you kind of get the vibe of it, and if you go off track, I'll sort of nudge you a little bit back on in the right direction. Okay, so should we go? Anil, do you want to go first? You logged on.
Sure.
Okay, so here we go. Case 1. So I've got a 65-year-old female who's presenting with shortness of breath to the emergency department. Okay, and so you're doing a Transthoracic Echo. So do you want to tell me, look at this study and tell me what you think? Is it coming out okay over in India?
It is. I don't know whether the speed is a little bit slow, but okay. Well, this is apical 4-chamber LV focused view. And I just want to get that lingo exam, so I don't know whether when you said punch,
it's a really nice thing to start off with saying, you've got a focused apical 4-chamber view. Yeah, absolutely, that's great.
Okay, and do I need to comment on the image quality and all those things, or?
Yeah, absolutely. I mean, I think that's just start getting into the banter where it's not. You're not saying anything like, it's an apical 4-chamber view with reduced width that's, 15 centimeters depth. That's kind of, feels like it's almost like, the medical students presenting a chest x-ray. I think... so
what I can see is it's an apical 4-chamber view, LV focused. The image quality is a little bit suboptimal, but I can, from a visual assessment, it seems that the LV function is systolic function is slightly down, and in the apical region there is a hyperechoic area, which it is hard with the kind of image quality that I have. I'm suspicious about reduced systolic function, possible apical thrombus. I would need to do more views, possibly use contrast, and need to assess further.
Very nice, very nice. Okay, so talk to me a little bit about what else could be going on in the apex. You said you're concerned about an apical thrombus. Why, and what else could it be? What else is in your differential?
Okay, so why? Because there is there's a hyperechoic area in the apical region, and so that's what makes me suspect about possible mass. It could be thrombus, it could be tumor, it could be anything.
Fantastic. But anything else? So you said thrombus, tumor, anything else?
It could be an artifact as well.
Excellent. Okay, so how would you, if you want to try and differentiate between an artifact versus another structure, what else could you see on this?
Okay, so the LV function seems slightly down, but there is no obvious regional wall motion abnormality which goes against a thrombus.
Very nice.
An apical infarct, then that area would have reduced function specifically, and that would cause susceptibility to form a thrombus. So I don't see that.
Excellent.
And the structure itself is not mobile; it's pretty fixed. And so, although the suspicion of the thrombus would still or structure would still remain, but my gut feeling, given the fact that I don't have full assessment, just based on this view, I'm more suspecting more of an artifact rather than a thrombus.
So what else? Maybe your imaging to tell if this is an artifact?
Sorry, what should I do?
Yeah, what else could you do? What other images? I'm going to show you more images. I think the examiner will never normally just be one unless it's a really obvious sort of point and shoot. They're always going to have something else they're going to show you. So that's, you know.
Okay. So I would, in the same view, I would want to pan anteriorly and posteriorly.
Nice.
And I want to use other views. I'd use the apical long axis view and as well as the 2-chamber view. I would zoom structure. I would turn the gain down a little bit because to reduce the image seems to be very grainy, but it's a little bit over, so I would turn the gain down. And I would use contrast, ideally an LV contrast, or I could use color as a contrast if I don't have.
Okay, so let's give you some color.
So I could see the color going right up to the apex and going through the beginning of that structure. So my suspicion of an artifact is a bit more substantiated. But again, I'm mindful that color is also susceptible to error if it's excessive, if the color gain is too high or the Nyquist is too low. So I would want to still confirm the views, have multiple views, see the structure persist in all the views. Okay, so that's a apical 2-chamber view. Again, I see something in the apical region, but there is no obvious regional wall motion. So it's hard to say. My suspicion remains, but again, my top differential would be an artifact, and then I would look for a thrombus. I would still want to use an LV contrast. Okay, well, that's focused. Is it possible to pan anteriorly and posteriorly?
Yeah, I think it's really nice. So obviously, it's great to say that. I think that's the end of that case. It's really nice. Anil, so great. So let's say in terms of the marking grid, you know, there are certain punchy numbers that we'd have to hear. I mean, that would be a pass. I don't think it'd be a strong pass with that because I felt like I had to like pull a lot of information out of you. You know, this is just I think quite a good example of the cases you're going to get. You know, they're going to be clinically relevant. They're going to be real cases. You know, obviously, I'm not going to put this one in a in a textbook or something, but it's all about you know, clinically relevant stuff that you're going to see every single day. So straight from the beginning, I think just be wary of jumping in because there are a couple of things that you said right at the beginning of this. The first one you said that there is, you know, right from the beginning you say we're dealing with a zoomed apical 4-chamber view. You said slight reduction in systolic function. I think this is going to be, so the way you said it was slight reduction in systolic function, and I'm worried that there's a thrombus at the top of the ventricle. So you've got to just back it off a little bit, I think, and start saying a bit more of a systematic sort of formal approach. So it looks like a normal sized left ventricle, which's got at least, I'd say, moderate LV systolic impairment, and it looks globally impaired throughout. So we've almost got a global hypokinesis. Now so you immediately went for the thrombus. Now, obviously, the next thing that you kept on saying after I pushed you a bit was that, well, there's no obvious regional wall motion. So that's the kind of stuff that I'd be wanting you to say before you jump in, because it's obviously a huge diagnosis, right? You've got a massive thrombus or tumor sitting in the top of your left ventricle. What's far more common if you don't have regional wall motion abnormality, you're dealing with an artifact. And so that's the kind of, you know, clinical relevant stuff that I want you to get into. The problem is with the exam is that obviously you're going to be amped up, you're going to be nervous, you think I'm going to show you something like a thrombus or something, and you're going to sort of want to jump right into it. So just try and pull it back a little bit and think systematically, because you're absolutely right. This is an artifact, but I just want to try and get that thought process out of you. So again, slowly go through it. Say, you know, as I said, no regional wall motion abnormality. There's a structure that's sitting at the top of the apex. It's not great image quality. So how do I differentiate between artifacts versus other things? Well, that's going to be through the use of color, using other axis images, reduce my depth, change my gain, use other images, go off axis. Yeah? And just that kind of pattern so that it's, you know, you get through these questions that, you know, they start simple and get harder and harder. You know, you get through it as much as you can, okay? Cool. All right, Ali, you ready for one?
Yeah.
May I pause just to check that Seb has got online?
Yeah.
I'll tell you what, I'm just going to quickly just pull you into the next one. I'll let you have a read of it and have a look at it. Okay, so case number 2. 75-year-old female, collapsed at home, hypotensive, deteriorating in the last few months, hypotensive in the emergency department, and inotropes have been started. Go for it.
So in the sinus rhythm, but there appears to be a bundle branch block on the ECG.
Very nice.
It's a parasternal long view with reasonable image quality. I think there is a moderate reduction. Oh, hang on, let me start again. The LV appears to be dilated on this view. There's a moderate reduction in LV function, and there appears to be more affecting the anterior septal wall with probable hypokinesis of that wall. The posterior wall, by comparison, seems to be thickening reasonably. The mitral valve appears to be normal in its morphology, but the movement in diastole seems to be reduced, which would be in keeping with the reduced global LV function. But I'd want to see other views to make sure it's opening appropriately.
Nice.
And we're catching a bit of the chordy, and that's what just makes it a little bit hard to assess. The looking at the aortic valve, it appears to be there's a lot of calcification there. It appears to be thickened and not moving particularly well in this view. Normal RV size. The other thing to say is the septum is synchronous, which might be as a result of the bundle branch block, but other causes need to be excluded.
Nice.
Okay, so we've got M mode through the mitral valve at the top left. It's cutting through the LV at an angle, so I probably wouldn't use it for an estimation of fractional shortening. And equally, it suggests that the LV is significantly reduced, function is significantly reduced, but I wouldn't hang my hat on any numbers. I think you could also say there's an increased E-point separation, but again, the angle makes that hard to interpret. Looking at the, is that bottom one?
Through the mitral valve, yeah.
Is it? Oh, it's still through the mitral valve, the bottom right?
Bottom right through the mitral valve, yeah. Sorry if that's not clear.
Oh, no, that's okay. Oh. I'm not sure that I can see.
If it's not clear, so we'll move on. I think you're telling me what I need to hear, it's fine.
Yeah, cool.
Okay, this is a zoomed up view of the aortic valve.
So the aortic valve, again, it appears thickened. It's quite hard to distinguish the leaflets, but I think the non-coronary cusp is certainly thickened, and it appears to have reduced opening. Other things that we could do to assess that would be to put M mode through it, or to look at in short axis and to see the colour flow through that.
Excellent.
Oh, okay. So that's colour Doppler, still in the long axis view. Certainly gives the appearance of a narrow jet going through a possibly stenosed aortic valve. There's certainly a lot of turbulence indicated by variance in that colour, making sure that your gain settings are appropriate.
Excellent. So what are you worried about?
I'm concerned about a mitral stenosis, a significant mitral stenosis.
Mitral stenosis, sorry, back it up a bit. So, sorry, let's just, sorry, that's the mitral valve was down there. Sorry, this is the aortic valve, the zoomed view of the aortic valve.
Yeah.
Yep. And then this is colour through the aortic valve. So tell me which valve you're concerned about?
So we're looking at the aortic valve, colour through the aortic valve.
Yeah. So you said you were worried about mitral stenosis.
No, aortic stenosis.
Thank you very much.
Sorry.
That's good. That's good. Just checking. So why is the mitral valve? Because I just double checking. Because the mitral valve on the other image I said was not opening very well. Why was the mitral valve not opening very well?
I suspect it's due to the significantly reduced LV function.
Yeah.
So it's relaxing well in diastole and it's not filling, so it doesn't do the flappy bit.
Very nice. And this is the aortic valve in short axis.
So again, all of the valves leaflets appear thickened. Hard to tell, but it looks tricuspid, but the non-coronary cusp appears significantly thickened with reduced mobility.
Yep. Yeah, that sounds good.
Okay, so short axis view of the left ventricle at the papillary level. The LV function looks severely reduced, and my image is quite slow, but the
oh, Seb, you're here. Excellent. Hi, Seb. If you can hear me.
Again, there is dyssynchrony. The anterior and inferior septal sections appear to be akinetic. So apical 4-chamber view. Again, the LV appears to be dilated.
Okay. I'm just seeing if I can help Seb out with his sound. Sorry.
No, you're right. I'll just pause for a moment.
You got sound. Sorry, carry on.
So again, LV appears to be globally reduced function with akinesis of the septum. I can't see the apex or the anterolateral wall appropriately. I'd need to measure it, but the left atrium looks a little bit enlarged on that. Looking at
That's good. Let me move on and just show you this one. What about this?
Okay, so continuous wave Doppler through the aortic valve with increased gradient across the valve, with the caveat that that would suggest it's probably going to underestimate the degree of narrowing given the poor LV function.
Very nice. So if I gave you this information, can you see that now? So LVOT VTI is 14, LVOT diameter is 2. So obviously the next question I'm going to ask is, can you please tell me what the valve area is?
Oh, I have to do maths in public.
What's that?
I have to do maths in public.
Yeah, this is good call. Maybe you can use your phone.
So we use the continuity equation.
Very nice, yeah.
The aortic valve area times the aortic valve VTI is going to equal the LVOT VTI times the LVOT area.
Nice.
14 times 2 is going to equal, what was the aortic VTI? I've got 77. So 14 times 2 divided by 77. really small. 0.36 is what my math tells me.
Okay, so just let's go through it again, okay? So you did really well with that question, because absolutely this question is all about recognizing that you've got reduced LV function. The thing that I had, the prompt that I'm going to be saying is, what walls are you looking at during the analysis? You've got to recognize that we're dealing with at least moderate, if not probably severe systolic dysfunction. And therefore, looking at that valve, the morphology very much suggests that we've got a rip-roaring aortic stenosis. And this lady has probably collapsed because of that. She's got a burnt out left ventricle. Yeah. And then the next question would be, we're sort of running out of time a bit, so I'd have probably just jumped on. But the question would then be, okay, so what do you want to do? You know, then it's about the management of aortic stenosis in a sick elderly patient and trying to get them through to stability, so you can do a butamine stress test to figure out if changing the valve's going to save their life, or are they in a whole bunch of trouble. So this is a really great question from separating the men from the boys, this one, because doing this in the heat of battle, you know, I expect you to be able to do this on the fly, in the ED, figure out what a valve area is so that you can talk with cardiologists. And, you know, this is good level, advanced echo. The further things that I'd like to have come out, you know, obvious past that question for you, but to make the sort of icing on the cake would have been, I guess, just speeding it up just a little bit, but that's not a major thing. Talking about recognition of the appropriate Doppler angle, particularly on this this picture. You know, you started off by saying that you were talking about the image quality. I think it's really important to do. Talking about wanting to analyze the aortic valve from lots and lots of different angles. Yeah. Doing this suggests that we've got severe valvular dysfunction. Yeah. Let's work on the continuity equation. So the equations that I'd be doing, you got it right, but I think you plugged it in wrong. So first of all, it's LVOT diameter, which is pi r squared, or 0.785 times the diameter squared. So that's 2 times 2 times 0.785. Yeah, and I think you might not have squared it.
Yeah, you're right, I didn't.
Yeah, and then you times that by the VTI, so that's times by 14, divide that by 77, gives you a valve area of 0.6. Yeah. Okay. So you'd have a calculator with you in the exam to help you out. You wouldn't have to do it in your brain. So yeah, I think this is certainly one of the things that I'm trying to bring more and more into the DDU exam, which is valvular analysis and being able to do it accurately, understanding limitations with what you're doing. Just being confident with coming up with things like valve areas and when to use the continuity equation and things like that. Okay.
No worries. Thanks.
Cool. Seb, can you hear us yet? No.
It's not there anymore.
No. Okay, and Neil, do you want to have a go at this? Case 3. So these are going to be, a few of these will be a little bit faster, and they'll be just point and shoot questions, okay? So let's have a go at some of these. Okay, so if you can't see where the actual Doppler stuff is, please let me know, because I'm happy to sort of tell you where that's, where the Doppler profile is if you need it.
Okay. So should I look at the image or just at the Doppler?
Both. So it's just about spot diagnosis. You can just tell me what the diagnosis is.
Okay. Well, this is across the aortic valve. So
okay. So this is not. So this is through the short axis view with the pulsed wave Doppler at the right ventricle outflow tract.
At the RVOT.
RVOT.
Okay. Well, look. So the velocity across the RVOT, the forward, so the heart rate is 55. So there's mild pulmonary regurgitation, and there's forward flow across the pulmonary valve.
Yeah.
And so the forward flow is below the baseline. The pulmonary regurg is above the baseline.
Very nice. Yep.
And I'd like to measure pulmonary valve acceleration time.
And how would you do that?
So I can't point it. Can you?
That's why it's quite good like this. Maybe you just got to try and describe it. It's all about describing what you see.
So I measure from the baseline at the beginning of the forward flow and measure. Can you see my arrow?
No, I can't, I'm afraid. Sorry, but I know where you're pointing. You're saying it nicely. So from the beginning of the forward flow, and the forward flow is above or below the line?
Below the line.
Very nice. Yep, cool. And where's the next point in time?
And the next point is along the spectral Doppler trace.
Yep.
Towards the tip of the spectral Doppler trace, and that'll give me the time. And I'd like to know. It'll give me an idea about whether or not there is the pulmonary artery pressures are high or not.
Okay, and what's the magic number that you use to say whether pulmonary artery pressures are high or not?
Very high, less than 60.
Okay, is there anything else in the morphology of the pattern that you can see there that gives you any information?
Also, there's a notching. There's a systolic notch.
Excellent.
That also points towards high pulmonary artery pressures.
Fantastic, very nice. So this is an example of pulmonary hypertension, and we call this the flying W sign, if you hadn't heard from it. But absolutely, that notching and the reduced acceleration time are both indicative of pulmonary hypertension. Very nice. What about this one? So let me say that this is a pulsed wave Doppler profile, and that's an apical 4-chamber view that you can see at the top. And that's if you can see my marker. So we've got the left ventricle up here, and this is the left atrium down here, and the pulse wave Doppler is just behind the left atrium in the apical 4-chamber view.
Oh, so, okay, well, this is an attempt to profile the pulmonary venous inflow.
Excellent.
And so the patient's in sinus rhythm, not in AF, because that then makes it easier to assess inflow. So I can see an S wave and a D wave, and the S wave is dominant, which should be normal in adults. And
okay, hang on, you said S wave and D wave. Where's the S wave during the cardiac cycle?
So the S wave would be systole.
Excellent.
Sorry. I take my words back. So systolic. So this diastolic. The D wave is smaller than the S wave.
Very nice.
The S wave is smaller. So that would sort of make me think about diastolic dysfunction and assess it more.
Yeah, very nice. Okay, so diastolic dysfunction, take me a little bit further. So we've got an S wave here that is much smaller than the D wave. So systole again from the beginning of the QRS to the end of the T wave, and then diastole from the end of the T wave to the beginning of the QRS. So here the S wave is much smaller than the D wave. So what does that indicate? You said diastolic dysfunction, is that right? Hey, Brad.
So the S wave is.
Yes, the S wave is smaller than D wave. You said diastolic dysfunction. You're absolutely right. It's just.
Yeah. So the left atrial pressure is high.
Yeah, fantastic. Raised left atrial pressure. Very nice. Okay. Hey, Brad, can you hear us, mate?
Yeah, I can now.
Fantastic. Thanks very much. We're just, Seb's almost on, and we'll get you up for one in just a second. Just so you know, Brad, we are recording this so that a couple of people who couldn't attend can maybe watch it a little bit later, okay?
Sure, man.
No swearing or, picking nose. Okay, a little last one for you. What's this one? So this is pulse wave Doppler sitting there in the, and that's the liver that we can see up at the top, and that's the IVC just underneath it. So we've got the pulse wave Doppler sitting in a vein that's entering into the IVC in the subcostal view.
Yep. So it's in the hepatic vein. So there's profiling the pulse wave profile of the hepatic vein.
Yeah.
And well, from the picture, the IVC looks very dilated.
Yep.
From a Doppler standpoint. So there is a hepatic vein. So the above the baseline is an S wave.
Nice.
And below, and then there's a towards the end of the systole, there's a reversal. So there's early diastolic reversal. That is, no, sorry, I'm wrong. So there's systolic reversal in the hepatic vein. So this is high right atrial pressures.
Fantastic. And what pathology can give you really high right atrial pressures? Particularly systolic flow rate that we're seeing here.
Yeah. So anything that elevates the right atrial pressures, it could be a failing right heart, it could be pericardial effusion, tamponade, and anything, pulmonary hypertension with lots of TR.
So this is particularly an example of severe tricuspid regurgitation. Is one of the most common presentations for systolic flow reversal. So it's not just raised right atrial pressure, this is actual reversal. So if I just show you, so have a look at this one, and with the S wave above the baseline in the hepatic vein, you've got rip-roaringly raised right atrial pressure. So that's often seen as severe tricuspid regurg, as opposed to this one where we've got that S wave in the pulmonary vein. It is just smaller than the D wave, and that's a sign of raised left atrial pressure. And that could be, at least moderate MR, rip-roaring diastolic dysfunction, and raised left ventricle end diastolic pressure. If we have actual reversal of the S wave, and that's when we start saying that's severe, severe MR from a flail leaflet or whatever. Okay, nice. Okay, Brad, do you want to take this one?
Sure.
Okay, it's an easy one. So 34-year-old lady, 35 weeks pregnant, G1 PO. She comes to ED complaining shortness of breath for the last 5 days, which has got worse acutely. She's tachycardic, she's hypoxic, she's got low PO2, she's got a low CO2, got blood pressure of 100 systolic.
Yeah.
That's what a chest X-ray looks like.
Okay. So parasternal long axis. So LV function looks good, albeit LV may be underfilled. She may or may not have some mild LVH, but probably not too much. Mitral valve and aortic valve are working well, and from this view, the right ventricle looks a little bit concerning, but obviously want to see further views. There may be a little bit of fluid in her lung, but there's no sort of significant pericardial effusion.
Fair enough.
Okay, so it's a parasternal short axis. So there's clearly now RV dilatation, and there's also a D-shaped septal compression of the septum towards the LV. It's probably, I'd like to slow it down, but the LV does still become circular in systole in terms of whether it's a volume or pressure overload. So there's definitely volume overload in diastole, but in systole there seems to be less compression, less sort of more normalisation of the septum. So the apicals will be quite useful if they're following.
Yep.
Okay, that's interesting. So pulmonary pressure, so the first one is the Doppler trace of a TR, which shows a gradient of 55, which estimated pulmonary pressures make an assessment of her right atrial pressure, but even assuming it's only 5, it's going to be 60, which is a bit high for with the pregnancy and the rest of it. The sort of initial presumptive diagnosis is going to be PE, but and I'm sure that's still top of the list. But the primary pressures are a bit higher than you'd expect. Generally, when you get pressures over 40, you start to get the pressures higher than that. A little bit uncommon for sort of super acute PE, but that's probably still going to be the diagnosis. Now, looking at the apical, she's got RV dilatation. And you'd probably say that's severe because the RV is starting to take over the apex.
Yeah.
The measurements on the side are probably 4.5 to, I'm guessing, at the base there. And she's got akinesis or dyskinesia of the mid sort of free wall, which is sort of McConnell's sign. The RV is a little bit prominent, the RV walls. So I'd like to know if there's any sort of background in terms of previous PE or other things that can affect the RV. And then the other thing that you see is that the LV is pretty empty and underfilled and hyperdynamic, which is pretty typical in this. And finally, the right atrial, interatrial septum does seem to flick towards the left more so than the right, indicating raised right atrial pressures.
It's really nice. So what do you want to do? So the story is, again, this young lady pregnant for the first time, this echo appearance. How are you going to put that back into clinical scenario?
So it depends, I guess, on how she looks, but I'd still probably like to confirm a diagnosis with some form of imaging.
Systolics are 100, tachycardic, hypoxic.
Yeah, I mean, I'm not, obviously there's a risk of thrombolizing this lady with she's got a baby inside.
Yeah.
So I would still probably try and get this lady for a CTPA, because I'd still be considering a catheter-directed lysis plus or minus embolectomy type sort of scenario.
Yeah,
and that's pretty impressive saddle PE with PE across both main pulmonary arteries.
Yeah, really nice, mate. Just going to bring you back to one thing, if I may. So talk to me about the diagnosis here. You made a hypertension. Hypertension of hypertrophy of the left ventricle.
Yeah, so I mean, I probably wouldn't make that diagnosis based on this.
What do you think you're seeing here? Why does it look a little bit thickened?
So it's empty.
Yeah, nice.
So it looks a bit more prominent when you're looking at it, but if you measure those, I wouldn't be surprised if they're normal or close to normal.
Yeah, cool. I mean, it's beautifully done, mate. Obviously, that's a really solid pass. It's it was nice. This is kind of a nice, easy one. Obviously, you absolutely smashed out of the park. And I think the things to maybe just pick up is when you do have an underfilled ventricle. Yeah, again, just be careful. You're not dealing with pseudo hypertrophy or the ventricle looking thicker when it's all squished down and underfilled. You mentioned the right ventricle size and function that looks bad on this, but you always want to see more images because it's not the perfect view for it. And you said all that. Noticing, talking about the D-shaped septum, systole versus diastole. I mean, I think it's kind of D-shaped all the way through that cardiac cycle, but, that's probably open for opinion anyway. But it really nice backs up what you were seeing on that first image of a massive right ventricle and hyperdynamic underfilled LV. And then completely agree with you about the tricuspid regurg stuff here. Nice. Where are we up to? Which one's this? Ali, do you want to do this one? So these are, again, rapid fire lung ultrasound examples. They're all just, the diagnosis straight as you see it, okay?
I see A lines and a suggestion of, my image is quite slow, but the suggestion of pleural movement.
Yep.
So I don't see any significant abnormality in this.
Very nice.
So multiple thick B lines greater than 3 in this lung field, suggestive of an interstitial syndrome, such as acute pulmonary edema, but wouldn't fit in the clinical picture.
Very nice. How do you define a B line?
So a continuous line that extends from the pleura all the way to the bottom of the image.
And what does it do to A lines?
Oh, it obliterates them.
Very nice.
Right. So liver on the left of the image and hypodensity above the diaphragm, suggestive of an at least moderate pleural effusion with the curtain sign coming in. There's a small amount of consolidated or atelectatic lung within that effusion.
Very nice. How do you estimate the size of an effusion?
There's maths. I don't remember. It's moderate.
I just take the maximum, the maximum, what do you call it, blackness, and times it by 200.
Thank you.
And it gives you an estimate. It's not hard science. There's maths involved. Yeah,
Isn't it 20?
20? Is it 20? So I thought it was 200. 1 centimeter makes 200 mils.
I think it's 20.
Oh, sorry, I didn't millimeter. Yeah.
Sorry, I had it as 200. I could be wrong.
No, well, if you're doing centimeters, it is. I do millimeters. So sorry.
Oh, sorry. I do. Yeah. Perfect.
Yeah, you're right.
How about this one?
Left mid zone. So you're getting it's consolidated lung by appearance. It has a hepatization type appearance with some air bronchograms evident within it.
Very nice. What's the diagnosis?
Oh, densely consolidated lung, clinical context, but it's probably pneumonia.
Very nice, very nice.
So you're going to call those dynamic air bronchograms? Yeah, that's air moving up and...
It's exactly right. So I think dynamic air bronchograms suggesting that we're dealing not with atelectasis. So I guess atelectasis could be this. I think this points more towards pneumonia because you're seeing air movement or gunk moving around in the airways rather than no movement at all. Yeah. So dynamic air bronchograms is probably a better way of saying it rather than just air bronchograms. Nice. Keep going, Ali. You're almost done.
So it's, there's a large pleural effusion with, again, atelectatic lung evidence in the base. The effusion's heterogeneous with suggestion of moving particles within it, which suggests it's a complex effusion. You'd be concerned about a exudative effusion or an infected. So,
very nice. How's it showing up? Is it showing up okay over there in the Northern Territories?
I'd like to blame the Northern Territory's crappy internet, but
is it my picture instead?
No, it's probably me. Like it's so. I sort of see the pleuris sliding in. I think it's sliding in and out.
Yeah, nice.
Yeah, I'm not sure.
Anyone else?
Lung point?
Just tell me why. Talk me through it.
Oh, because there's a transition zone. So there's a movement of pleura and there's no movement of pleura. And they're still within that Merlin space between the two ribs. So it suggests, if it is an anterior, it suggests a small pneumothorax.
Yeah, cool.
The between mobile pleura and then there's nothing. Sorry, I can't point it with my hand.
That's good. That's excellent. Well done. Yeah, lung point sign, maybe small pneumothorax. Very nice. All right, Anil, this is yours, buddy. Oh, sorry. Why don't we? So this is a toe. I've got, I think. No, sorry. Cancel that, Anil. This is transthoracic. It's all yours. This. So recent admission with urosepsis. During that admission, we had a negative toe because she also got a history of staph endocarditis in the 1980s, and she was found to have a bicuspid aortic valve. Then she needed that replaced about 15 years ago or so. And then she had a redo 4 years ago because of severe AR. So in summary, it's a middle-aged lady. She's represented with worsening dyspnea and orthopnea, background history of bicuspid aortic valve, staph endocarditis, and 2 redos. Okay? And she's now short of breath and with worsening on lying down flat.
Okay. This is the parasite long axis view with obviously multiple surgeries, difficult imaging. The image quality is possibly understandably suboptimal. What I can see in this parasite long axis view is the LV is larger than RV. LV size appears slightly dilated, but I would like to measure it. The systolic function. So the patient's sinus is the systolic function is at least mildly impaired, but and the base is not contracting as well as the mid segments. And the left atrial size doesn't appear enlarged. And I can see the prosthetic valve or is well seated. I'd like to put color to further assess. And I'd like to look at multiple views to substantiate my system. Okay, well, so there's flow acceleration. I'd like to slow it down to see which phase of cardiac cycle it is.
Yeah, it's a bit dodgy, this picture. Yeah, fair enough. I might just move on. It's not great, excuse me. Neither's that, actually. Hey, how about that?
Okay, so the LV is dilated, and the RV looks a little bit dilated. LV function is, I would say, at least moderately severe, possibly moderate to severely reduced, and the basal segments are not contracting very well. There's possibly some actually regional wall motion normalities. The left atrium also appears slightly dilated. There's no pericardial effusion. And I'd like to assess, given that the patient has had multiple aortic valve surgery, I would like to go into a 5-chamber view and assess the valve with 2D color and as well as spectral Doppler, with a zoomed view as well.
Just before we move on, can you tell me what walls we're looking at in the left ventricle? What wall's this and what wall is this? Can you see the arrow there? So what septal wall is this and what lateral wall is this?
So that's anterolateral towards the lateral side. So that's the lateral wall. Sorry, put your arrow again.
Sorry, this wall here is which wall? You said it was the anterolateral. Yeah, that's right. What about this wall over here on the left?
So that's a septum.
Yeah, which one, anterior or inferior?
That's so the bottom is inferior septal region.
Thank you. Okay, you wanted some color. There you go.
Yeah. So I can see a degree of mitral regurgitation. And it's at least moderate, I would say, and it's hard to just comment on the severity of mitral regurg based on that view alone, but I would say at least it's moderate, mild to moderate at least, and well, even the valve opening, I cannot appreciate the valve opening very well. But there is no obvious, I like to slow it down, but there's no obvious flow acceleration in the diastolic phase. So I'm thinking about whether the mitral valve stenosed as well, but I'm not able to just conclusively do that. I'd like to do the gradients across the mitral valve and possibly have a continuous wave across it.
Okay, so this is across the aortic valve.
This is to the aortic valve. Okay, the velocities. So the forward velocities are a bit more than 2 meters per second, and which is not surprising given the multiple surgeries the patients had. And then there's closing click after the spectral systolic spectral trace across the aortic valve, and then in diastole. So there's aortic regurgitation as well, possibly.
I'll ask you just to focus on this cardiac cycle just here, please. Just the last one of the 4, please.
Okay. So this, all right. So Sam, are there two? So this is across the LV aortic valve.
Yeah, and this lady's really thick, I should say. So she's sniffing a shorter breath, so it's not easy. So I think we're capturing both, actually.
Yeah. Okay. I'm not sure what I'm not sure what the trace is above the baseline.
Yeah, it's tricky. It's not perfect. It's not perfect.
Is it? Are we capturing the pulmonary venous inflow above the baseline?
No, I think this is aortic regurgitation. This may be a bit of an artifact, a bit of what do you call it? Reflection artifact on Doppler, because we're dealing with the artificial valve. So it's particularly this area here. What do you think about this?
So also, there's early peaking. There's early peaking and it touches the baseline. So this is severe AR.
Very nice. What's this?
Yeah. So this is again during diastole.
Nice.
And so this is forward in the direct. Okay.
I guess this is for gold. This is for gold marks, but anyone else want to take it? What are we dealing with here? Brad,
Is
what
that
do you
diastolic? No.
So through the aortic valve, right?
Yeah, so through the, or whether I was thinking whether it was cutting across, in the mid segment when you can see also but this is not.
So what stage of the cardiac cycle are we in?
So this thing that you pointed is in diastole, obviously.
Yeah, nice. Is it particularly on? I think I might have the screen.
Oh, so this is the atrial. Okay, well I get it. This is the atrial kick, which is this is suggestive of high LV and diastolic pressures.
Boom, and we've got that from severe aortic regurgitation. So I didn't show you the money shot. Can I just ask you to look at this again? So you said that you thought this was a well-seated aortic valve. Do you want to now, we've had a look through it again, do you want to just have a look at that aortic valve?
I don't think it is well-seated. It's the bottom part is it's dissynchronous with the top. So I don't know.
And so what's the magic word for so if we've got a bioprosthetic aortic valve that's sitting in there and it's rocking, we call it being...
Yeah, rocking motion. So it's about valve dehiscence.
Yeah, very nice. So massive dehiscence is sitting in there. So that's a very, very badly seated bioprosthetic aortic valve on the background of multiple surgeries, and she's been in hospital with urosepsis. That was probably a bad call. I know she's had a toe, but we've missed something. She's then gone home. So I'll just bring up the story here again. So recent admission for urosepsis, negative toe, representation with worsening dyspnea and orthopnea with this horrible history of redo after redo. And then with that looking structure, we're looking at someone who's got a horrible dehiscence of the bioprosthetic aortic valve. The left ventricle doesn't look too bad. So these are a bit crappy pictures. This one, you see this artifact that's coming through here that's just going backwards and forwards.
Oh, yeah.
We didn't see on other images. So I think this is artifact, and I think this artifact is coming from the bioprosthetic aortic valve. And obviously then going off axis, I could show you a much better picture of the whole thing just sliding in and out. But here we can see this really weird, eccentric, chaotic, big, thick color regurg from the aortic valve or in the LVOT region that just looks really odd. So again, it's just recognizing those, it's all about clinical acumen, that something's not right. And maybe that's me writing a bad question. It should say this lady's really, really sick, maybe. But everything points to this one here, I think, is just, it's beautiful. I mean, I think we're seeing here, exactly as you said, this aortic regurg with rapid equalization of pressures. Then you've got the aortic flow that comes through when you're sitting atrial systole, and that's suggesting horribly raised left ventricle end diastolic pressures, probably acute, and that's what is giving this horrible sort of restricted pattern to the LV, and this lady is in a whole bunch of trouble. So what the images would you like? Transesophageal echo, you've got to have a look at that valve, try and see if she's well enough to go for an urgent ventals or something, but I think she's in a whole bunch of trouble. Cool. Any questions about that? Is that okay, Anil? Any questions? All right. Brad. Oh, you'll like this one, Brad. Okay, so 54-year-old lady. She's got an elective admission for an angio after a recent non-STEMI with an AKI. The angio was delayed to allow the kidneys to recover. So she went for the angiogram, and we're called after that procedure. She's had a difficult procedure with an episode of bradycardia during the procedure, and they were worried about a small RCA dissection, and they put a stent in, and they said they sorted that all out. So she's with us overnight, as there's no CCU beds, mainly. And then we were doing a tow the next day just to follow up from all of this.
All right. So this is mid-esophageal, just looking through the 5-chamber or the aortic valve. She's got what looks like pretty good LV function. Aortic valve looks okay. Right ventricle looks okay.
Cool. What walls are we looking at here? So this is meant to be a 4-chamber. She's just a little tricky. What walls are we looking at on this view?
So anterolateral and infraseptal. So this is probably rotated around to, no it's not, where's your little, oh, still at 0 degrees.
There's still 4 chambers with the colour on now.
Yeah, okay. So she's got some mild TR, MR, sorry.
Nice, yeah, it's on the left.
Yeah, thanks. Okay, so now we're sort of heading around towards a commissural view.
Nice. So what walls this one on the left?
Inferior and anterior, but we're sort of moving towards those, so they're sort of 90 degrees. So, again, walls look okay. Left atrium looks okay from what I can see.
Cool.
Valve looks okay. Okay, so this is your sort of your long axis or 3 chamber. And so
finally, if you just tell me the walls, what wall have we got here and what wall have we got on the inside?
Yeah, so anteroseptal and infralateral.
Nice.
Aortic valve, I think looks all right from what I can see, but it's a bit hard to make out the picture in the right ventricle. Actually, okay. So she's got some central aortic regurg. On the 2D, I don't know, it's sort of hard to make out in these pictures. I'm just wondering whether she does have a little bit of prolapse of one of the leaflets.
Nice. Start giving you a bit more.
Okay. Well, all over the place. Yeah, so this looks, let's see how they're opening. Okay. So this looks concerning for a perforation of one of the valve leaflets.
Okay.
And she's got a regurg right through where the concerning point looks. It is when they're opening okay, but when they're not really coacting right. So that's yeah, central aortic regurg. And okay, so I mean, again showing some aortic regurg there, but trying to make out where the hole is.
Yeah,
nice to see it.
Tricky, it's nice to understand. Anything else?
Yeah, she got a dissection as well.
Fantastic. What kind of dissection?
So there's just on the proximal wall there, the wall near the left atrium. That's, which is, I guess, where the right coronary comes off. There's some there you can see the intima separated from the aortic wall. So yeah, they've caused, well, I assume probably caused a dissection through putting that stent through.
Do you have a classification for it? Just give me a little bit about that.
Oh, so it's a type A dissection.
Nice.
And you'd be worried about, I didn't see any right coronary issues, but you'd certainly be worried about have a close look at the right ventricle walls.
Really nice, yeah.
And yeah, that's pretty concerning. So, so you can see the dissection there, which is around the right coronary cusp.
Yeah. Which cusp is that one?
That's the non-coronary.
Nice. That one?
That's the left.
That one there? Sorry, the one at the bottom?
Sorry, so that's the right.
Nice.
Right.
And then that one at the top is the?
Yeah, left.
Sweet. And then this bit in here, that echo free space, that's the bit that's a bit worrying, obviously.
Yeah, and you just, assuming they haven't gone through the wall, but we want to see some colour areas to make sure it hasn't gone through to the into the right ventricle. But that's yeah. I mean, there's
nice.
Show any sort of jet going in outside the aorta. And
then that's just pulling the probe back a little bit.
Yeah. So this is just you can see the intimal flap there, just flapping around in the proximal aorta.
Yeah, which one do you think is the true limb and which one's the false one?
So the one that expands in systole is the one in the middle, I think.
Yeah, nice one, excellent. And then this one's looking down to 40 degrees down in the descending aorta.
No, so it goes all the way down.
Yeah.
Okay, and then so then it'd be nice to have a look at the neck vessels as well if you can get a view of those.
Yeah, good call, really nice. Excellent. We've probably run out of time a little bit there. Maybe I'll just flick through the last case that I've got here just to show you the last example. Or Ali, have you got time? Ali, do you want to quickly just smash through it? Okay, Ali, this is all yours. So 76-year-old male, hypotensive after intubation for a pneumonia, rapidly escalating levels of inotropes.
So apical 5 chamber. Left atrium appears a little bit enlarged, just eyeballing it. Mitral valve appears to open and close normally with normal morphology. The basal inferior septal looks hyperechoic and a little bit thick. My image is quite stilted, but the LV appears to have reasonable function in the
yeah, so why have we got the rapid escalating inotropes, do you reckon?
I don't know.
Anything you'd like to do next?
More images and try and do an assessment of his cardiac output and whether he's likely to be volume responsive. It looks a little bit hyperdynamic, but I'm literally getting 2 pictures per cycle.
Oh, sorry.
No, not your. It's seriously the NBN's got a lot to explain for. Well, that doesn't look very good.
Oh.
So continuous wave through the aortic valve appears to be a reasonable angle from that one view, but you'd want multiple views. Increased gradient, a significantly increased gradient across the aortic valve. Yeah, I think the shape is symmetrical.
Yeah.
So you'd be concerned with the sort of potentially hyperdynamic, slightly underfilled appearance, plus that thickened septum, about getting a like a dynamic flow obstruction as opposed to an obstruction at the aortic valve. So you've done pulse wave Doppler a little bit away from the aortic valve. I can't interpret anything particularly meaningful from that.
So if I were to do this in you, what level would I have the LVOT reaching? Ooh.
So as in the LVOT VTI? Or
Yeah, exactly.
Normal would be about 20.
Yeah, beautiful, beautiful. So this one we can't measuring it. What's going on here?
So you've exceeded your Nyquist limit, and so you can't. The velocities are exceeding what you've got on the scale you've got on the screen.
Yeah. And so what happens when you exceed the Nyquist limits?
You can't tell.
Yeah, and it just wraps around. So it comes along to the top and comes back down. So we wrap around. What about this?
Again, you've exceeded the Nyquist limit indicated by the 2 red bars at the bottom. So you can't tell where the measurement is occurring at and what the velocities are. But if you look at the trace below the line, there's a suggestion, looking at the second cardiac cycle, there's a suggestion of a late peaking trace just near where you've got the arrow go a little bit left.
There's the golden mark just there. Very nice. Yeah, good call. Guys, well done. Yeah, that absolutely smashed that one. I don't think I've got anything else to say about that. I'll just show you this one. It's not the best picture, but I think whenever you've got that septum and, you know, normal LV function and maybe it's a bit underfilled and rapidly escalating inotropes, it's got to sing to you LVOT obstruction, and that's what you sort of said, so that's fine. Hey, nice one, guys. I'll just finish up with this then. Just say, obviously, it's the exam's not. I don't think any of you guys are going to have problems with the exams. You know, it's super clinically relevant. It's not. There's not going to be anything in there that's going to try and trick you out. It's a lot of the stuff's going to be in the stem. The examiners are going to help you keep talking. The only reason why some people have failed, it's because of obvious lack of knowledge, to be honest. It's the exam technique we're going to try and help you out with. You know, I understand people are going to be nervous there, but you know, these are not the worst cases you're ever going to see. They're not super challenging. You know, I don't think it's too much to ask you to estimate someone's aortic valve area. You know, you should know how to do that. But I'm not going to ask you to do a PISA or something, to be honest. And so just when you're describing things, I think it's nice to say what view you're looking at, but get through that stuff real fast. You know, go straight for the money. I have a spiel that I kind of use where I talk about the left ventricle size and function, right ventricle size and function, but don't get caught up too much on, you know, mild septal thickening, you know, when they've got a aortic valve that's swinging around in the wind. You know, go for the money and make it clinically relevant. Okay. In terms of Anil, so I prepared this as very much, you know, for the guys who are just doing the pure crit care one. So it's all going to be TTE, TOE, and there'll be something general in there, either aorta, lung, gallbladder, or DVT. For you, we won't have TOE, we'll just have congenital heart disease, and, you know, I'll have to do some reading up for that question. And we'll probably pass you on that one then. Okay. Are there any questions from you guys about that?
So Sam, just with congenital heart, but everything else would be same, isn't it? Because I have prepared, short of TOE, I have tried to read as much as I can lay my hand.
Exactly right. And so obviously we're going to take that into account when we've got you sitting there, of course, and we'll try to do it as best we can. Okay. Cool.
Thanks, Sam. That was awesome.
Pleasure.